So it's a pleasure for me to present to you today's speaker, Dr. Heike Rittner. Dr. Rittner is a professor of anesthesiology and pain medicine, and she is the head of the Center for Interdisciplinary Pain Medicine at the University of Würzburg in Germany. Dr. Rittner did her medical studies between Austria and Vienna, Würzburg in Germany, and Yale New Haven Hospital in New Haven, Connecticut. She trained in anesthesiology at Charité University in Berlin between 1998 and 2008. Dr. Rittner is a physician scientist. Her clinical focus includes pain medicine, interdisciplinary multimodal pain treatment, and complex regional pain syndrome. She is also a world expert on molecular and translational pain research in inflammatory and neuropathic pain preclinical models and clinical models with a focus on peripheral nociceptors and dorsal root ganglia. She's also working on regenerative medicine in plexus injury patients. Today, she's going to present their model of interdisciplinary multimodal therapy for chronic pain treatment. So without further ado, I'll leave the floor to Dr. Rittner. You are muted, Heike.
Okay, I guess now we are ready to go. Yeah, thank you very much for your introduction. And also I'm very honored to present, well, the way we're doing pain therapy for chronic pain patients in our institution. Since I'm quite far away from you, I would like to engage with you more, and I'm using this presentation here now to also include questions. So I get some ideas about what you think about certain topics. So you can either use the QR code, or you could go to www.menti.com and you enter the code 69055027. So I guess I'll leave it for a second. So my plan is now to explain to you what is chronic pain, how we treat chronic pain, and what I think the future is and where the challenges are, so to keep us busy. So the first question is just to get everybody on board is, what are your associations with chronic pain? You can just type it in your smartphone and it's just going to pop up here. So we will welcome everybody. Yeah, very nice. I'm also seeing, I'm already seeing familiar wordings like disabling, depression, fear and anxiety. Someone wrote, I think in the beginning, hard to fix, unremitting, passivity, trauma. Yeah, these are all the topics and also the words that I would associate with this. I would like to convince you later on that it's not just depression, but it's a whole complex of it. And to also get you all on board, just to remind you a little bit how pain is actually felt in the body. You know, all these sensory fibers, the nociceptors that will go into every part of our body except for a few ones where we don't have nociceptors, and the dorsal root ganglion is the body where the somata of these fibers are, and then they project into the dorsal horn where we find the first synapse, and via the spinothalamic tract it will move on to the thalamus and finally to the somatosensory cortex. Of course, pain is not only felt in humans, but pain is also controlled. And these are very simple pictures just to have everybody there. There's descending pain inhibition, which sort of originates in the central nervous system and then projects to the dorsal horn, where the system is modulated and can be inhibited. We usually classify pain in 4 different types of pain. The first type is nociceptive pain. This is actually acute pain without tissue damage. So whenever you feel something hot or cold, which is painful, you have nociceptive pain. The second type is inflammatory pain. So whenever you have a joint inflammation or your tooth hurts, you had surgery, there's inflammation and this actually hurts. And the two here, neuropathic pain and nociplastic or chronic pain, are more difficult to treat. They include diabetic polyneuropathy or nerve injury or complex regional pain syndrome. So whenever the sensory nervous system or the somatosensory nervous system is damaged somewhere, it can be neuropathic pain. And what we're going to focus on today is nociplastic or chronic pain, for example, back pain, fibromyalgia, or osteoarthritis. For this talk, it's important to understand the differences between acute and chronic pain, because acute pain is what happens after trauma or injury. It usually lasts less than 3 months. It's usually protective for a tissue or life or tissue preserving function. It has usually an uncomplicated psychological processing. It's highly socially accepted. So if you have a broken arm, everybody feels sorry for you. And our job, being a pain physicians or pain specialists and also anesthesiologists, but I guess everybody else is, it's important to aggressively treat acute pain to avoid chronification. Chronic pain is on the completely different side of the coin. It usually lasts over 3 months. It's or recurrent and with a persistent disease. Very often, or what we have learned from the last years, it's often independent from structural changes, and it is its own disease. For example, if you do an MRI of the spine of a large group of people, you will find many degenerative changes, but that not necessarily correlates from whether their patients have pain or not. And it results in physical and mental exhaustion. From a pain physician and then also pain researchers, where are our major questions at the moment? What have we not solved? Although there are hundreds of new publications, and we know a lot more than we did 20 or 25 years ago. In fact, you might have seen that the Nobel Prize for medicine was awarded to the pain field 2 years ago, when it was the TRPV1 receptor, which is actually activated by capsaicin, was awarded to David Julius and Adam Pataputian. So what we don't know yet is how does this polynodal modal nociceptors, because they are activated by heat and by mechanical stimulus, how is this transmitted to the brain, and how does the brain actually know it's heat pain and not mechanical pain? I think an ongoing question is the contribution of peripheral and central nervous system to the feeling of pain. And that's actually also part of the collaboration that we're having with Rochester. So the centralists and the peripheralists. Sometimes we don't know why many blockers of selective pathways work fine in the mice, but not in the humans. One major question is, how can we measure pain objectively or integrate many factors to better understand the meaning of the visual or the numerical analog scale? And the last question is, how can we implement the biopsychosocial model of pain? And in my talk, unfortunately, I can't talk about all of them, but I will talk about the last one, which I think is very practical and important in everyday practice. Paul already introduced the Center for Interdisciplinary Pain Medicine. We have an acute pain service. We have an outpatient pain clinic. We have what I would call a pain day clinic and inpatient pain therapy. And of course, we teach people and we teach students so they know better in the next couple of years. And we do several research projects. If we think about chronic pain and how the field has moved in the last 20 years, there was a big step forward when the ICD-11 was actually introduced. Because before this, chronic pain was just part of the psychosomatic diseases. And now chronic pain is a separate issue or a separate entity. And what it actually means is that there's continuous or recurrent pain for more than 3 months. I explained this before. And there's a classification, which is dependent on the intensity, the interference, and the distress of the pain. And we're now talking about primary chronic pain and secondary chronic pain. And you can see there, there are numerous publications about the task force that actually tried to define these different entities. And for us, it's really important because we can better do research, and also we can better argue with healthcare providers if we can really specify what kind of pain this is. Secondary chronic pain is quite easy. For example, it's cancer pain or chronic pain after surgery. Primary chronic pain are diseases where we don't actually know what's happening yet. For example, non-specific low back pain, tension type headaches, fibromyalgia, or complex regional pain syndrome. They're all primary pain syndromes. And we're still exploring what exactly is the pathophysiology of these diseases. So I have one more question for you, voting. So does chronic pain increase the mortality? A quick one. Actually, when I was asking this question myself, I wasn't quite sure because you're right, it does increase the mortality. It's still not quite clear why this is the case. I guess everybody knows that cancer or cardiovascular diseases decrease or increase the mortality. For chronic pain, it was long not very well known. This is a study from Finland because they have programs for multimodal programs for outpatients, and they just used their original data and then followed up on these patients. And I think the important information is in the age group between 50 and 70, because this is when you see excess mortality between the sexes. So white is women and black is men. There's also an increased mortality for younger people. It's 3 times increased, and it almost levels down once you're over 70. The authors in these articles, they speculated about the reasons. One could be movement restrictions and lack of movement or psychological stress. But so also our healthcare providers or societies, so not treating chronic pain will increase your mortality. So we have an outpatient clinic, which we actually use to screen patients to make sure that they would fit into our programs. And we would also, if there are patients that just need some drug treatment, they would be just treated in the outpatient clinic. And we have several centers in Würzburg that also rely on sufficient pain treatment, like the Comprehensive Cancer Center or the Endometriosis Center or the Breast Cancer Center. So we work with these people to make sure that, for example, cancer pain is treated properly. But now coming to the special about chronic pain. And I think the special part about chronic pain is that it has this multifactorial genesis. So there are biological, psychological, and social factors. And this idea is not completely new. This has been already postulated by Patrick Wall, who's one of our sort of godfathers of pain medicine and pain therapy. And he once wrote down, our brain does not passively sit around and read the information coming from the tissues and the spinal cord. It sends out impulses that already change the incoming information. So Patrick Wall was an electrophysiologist, and he already saw that there is a connection between the brain. And so pain is not just nociception. And to explain this a little bit better, I'd like to use a review that was done by Irene Tracy several years ago, but it's still very good to explain what chronic pain is. So our current understanding is that there is some hardware at the birth. So your genotype, epigenetic profiles, your gender, like all these innate mechanisms, they make you probably prone to chronic pain or not. And then we have environmental influences, like an acute injury. For example, you get a prolapse of your disc, yes or no, or you have an accident. Sometimes there are diseases in critical developmental periods, and also sometimes there's stressful life events that are part of these environmental factors. They're acquired mechanisms. And then we have these interactions between genes and environment. So your personality, the psychology, pessimisms, anxiety. And what's a little bit missing in this model, I think, is all the social factors. So your family, your friends, your job, or whatever you are doing. And I'm always explaining if you just have one, so if you have a bad hardware or a prone hardware at birth, and you're a neurotic, an anxiety person, but you never have a prolapse, then you won't get chronic pain. Or vice versa. If you have the prolapse and you have the hardware at birth, but you're not very pessimistic and not very anxious, then you also don't get chronic pain. So you need a lot of factors that need to come together in order to have chronic pain. And the next couple of slides, I would like to show you how we treat, and quite practically what we use in the day pain clinic to do this. So we treat around 300 patients per year, and we have many treatment days, and we have also some special programs for certain subtypes of patients. And most of our patients are very chronic and very complex patients. So about 75% of our patients have the highest degree of chronicity and chronic pain. So we are sort of a referral center for complex cases. And what is this interdisciplinary multimodal pain therapy? It was actually introduced by a work group in 2009. And what the essence are actually three different things. So one is that we simultaneously apply different therapeutic methods. So it's not that you just give the patient a drug and then you just send him home, and when he comes back in 3 weeks, you just give him some physiotherapy, but no, you do everything at once. Number two is a multidisciplinary admission procedure with psychotherapeutic competence. So at first, everybody looks at the patient and gives his or her opinion. And I think also the interdisciplinary team meetings are very important. There has been a recent publication, same journal, again, that especially the team and the philosophy and the same goal in terms of treating these patients is very important. So I'm going through this a little bit now to make you understand a little bit. So what's my job, or what's the job of the physicians? Of course, they do the pain history and the physical exam. We look into what has done in terms of the diagnostic, and we especially would like to know what are medications, what did patients have done before. And we will check with the patients at this interdisciplinary admission procedure, the goals and the expectations. And we will also tell them already that we will not do many more tests. Of course, if a patient comes to us and there's something new, or we look at them and we see something that hasn't been explored yet, we would do that. But most of the time, patients had lots of diagnostics, so it's not necessary to do another round of MRI. Our goal is also less medication most of the time. And we also tell them right in the beginning, like one of you guys said, hard to fix. That's what we're telling them. So there will be no painlessness. We can improve things, but we are not, we don't do wonders. The psychological part is looks into influencing factors, the patient's concept of pain. I actually think that this avoidance and endurance, that just two types of people or patients. They're the ones that keep running, like they clean the whole house on the weekend and including all windows. These are the ones that have perseverance, and they're the other ones, the avoidance ones. They don't do anything on the weekends or during the week, and because I always think it's going to be painful. Of course, we also look at the biography of comorbidity, and one criterion for us also is the ability to engage in the group therapy. And the psychologists also talk about the goals and the plan, and also give them some understanding of what's going to happen in terms of coping, acceptance, and commitment to therapy. And then the last profession is physiotherapy. And here I would like to point out the patient-specific function scale. So we will always ask patients about what are the 3 important functions that you want to improve. For example, some patients say, well, I want to walk longer, or I want to be able to lift when I go shopping. And they also rate this in a scale between 0 and 10. And we also look into how is this function actually improving. Or patients say, I wanted to go dancing again. And it's very individual, but also gives the patient some control about what's going to happen and where the focus should be. Of course, they also have to be able to participate in the training groups. And what the goal is to have the right level of fitness, less fear avoidance, and active training. We are not a massage clinic because we don't think it's helpful. We have one mattress, which is a treat once in a while, but it's not the focus of the therapy. And this is a little bit how the timetable looks like. We have certain color coding. Everything in yellow is sports, everything in green is psychology, and blue is, I think, doctors and nurses. So we all know what we're supposed to do. And then we have, after everybody has seen the patient, we have a team meeting and discuss whether the patient is eligible for the treatment or not. And also we have a few special programs, one for elderly patients and one for CRPH patients. And at the moment, we are working very closely with the pediatrics to have one program for teenagers, which will be completely different, but also an outpatient one. So I pointed this out up here. So I think education is always part of it. So we explain the patient what happens, how he should use the medication or not use the medication, and we do some medical treatments. I will later in the talk point out about the drugs that we are using. Most of the time we reduce, so we try to discontinue non-opioids and also opioid drugs, or at least see whether they still work or not. And whether if they work, what they actually do, is there really an improvement, or is they just sedate the patient or something. So we just look at all the drugs. And as I said, we could do further diagnostics because we have the whole university hospital and all other specialties if we need to. We also work very closely with psychiatry. So whenever we have a question or a problem here, we can consult those. And the goal is to do pharmacotherapy according to guidelines. And we really rarely use invasive therapy. In physiotherapy, we do functional training and the patients get individual physiotherapy and also education. And the goal is to have better fitness and normal physical activity. And actually, the groups are really very well. When I started in Würzburg, which is whatever, 12 years ago, there was some questions whether patients with fibromyalgia would ever be able to do some training. And I wasn't quite sure whether this is possible because they had pain for such a long time, but it works really well. We have very good physiotherapists. They sometimes adapt the functional training, and we use functional training based on machines, but also we have just regular gymnastics or Tai Chi, and we just implemented a group with yoga. So the idea is to get a better feeling of your body and the right level of fitness. Of course, if you ask me what's doing this, I actually don't know, because the patients do, for example, strength and cardiovascular training, whether they have osteoarthritis of the knee or back pain, or if they have tension type headaches, it just helps. Of course, they also get some special treatment, so they would get some special exercises they could do. And we use certain apps to show them the exercises that they're individualized for them. In psychotherapy, the goal is to understand the biopsychosocial nature of chronic pain. Our psychologists diagnose and treat comorbidities, and the goal is the self-efficacy. We have a long focus on group treatment. For example, we're explaining pain. We explain how pain and depression are connected, how pain and sleep is connected, and what patients can actually do. And also relaxation techniques are offered so patients can decide which type of relaxation fits them best. And we have some social competence training and open groups where individual problems can be discussed and solutions found. For example, how do I talk my employer when I come back if I want to have my workplace adjusted according to my needs, or how do I talk with my family if I want to explain them what's happening with me and what they should do with me. We also have nurses and social workers. The nurses are doing the relaxation groups and aromatherapy and creative therapy. And of course, we do social counseling, and mainly social counseling is about return to work. Of course, also application for disability funds or social participation. And if patients have to apply for retirement, or if for disability funds, then we would also look into what else they could do to participate in everyday life. Of course, which patients are not suitable, which ones, and this is why we need the assessment to make sure that we have the right patients. So if they have severe psychiatric comorbidity, we're not going to treat them in our pain clinic. They would probably be better suited in psychiatry. Personality disorders depends a little bit on the severity. Psychotic disorders is a contraindication. We sometimes have patients that have suicidal ideation, and that's why we need to work very closely with the psychiatrists. And that works actually quite well. So it's not an often problem, but sometimes it is. We have surprisingly many patients with PTSD, although sometimes I think it comes in cycles. So we just had a cycle, and I think it's waning off a little bit. I don't know why. Also, the second contraindication is if the psychiatric comorbidity, the morbidity is the most important one. If the patient, yeah, I have pain, but my major problem that my mood is bad and I can't motivate myself, then if pain is not in focus, then we will transfer the patient. And actually, we need German language skills, because a lot of the program is based of understanding German. And this is sometimes indeed a problem if we have people coming from other countries, and we have to probably work on this again. There's some relative contraindications if patients have a pure biological concept of pain. So if they come to our clinic and the only thing they want is more diagnostics and highly invasive treatment, this might not be the right patient. On the other hand, sometimes we are sort of a door opener, because we treat both. We treat the biology, we treat the body and the brain and the personality and the person as a whole. And we've often seen that this is even though they have some, they don't think they have depression, and they don't see the connection, it's good. If patients have no motivation for change, well, then that we might not be the right place. If they had the same similar therapy before, I did write down very low intellectual level. That's really a problem. We can sort of manage and adapt when we do the educational part, but sometimes we think it might not be the best therapy. There might be better ones. Next question for everybody. Now, which parameter would you like to see as an outcome of the treatment that we are offering? I'm giving you 4 different ones: pain intensity, mood, physical function, or return to work. I would just be interested in what you would like to see. Yeah, this is very interesting because if you look at the studies, everybody's looking into pain intensity, and it's not the highest score. I also think that physical function or social participation is the most important one. But of course, we are a pain clinic, so we have to look at pain. Mood is important. Return to work is important if patients are still working, but if they're not working, of course, this might not be an issue. Okay, there has been a group around Ulrike Kaiser from Germany, and she has very long looked into outcome parameters, and there was a pain consortium that was a European network with all the stakeholders in pain therapy. And they actually defined 6 dimensions of outcome parameters. Of course, pain and pain frequency was the first one. But then you can see physical activity was actually the second one. Emotional well-being, the number 4, satisfaction with social roles and activities, as well as productivity, paid or unpaid work at home. And then health-related quality of life. And I think what they thought is very important also to get what the patients actually think about how good the therapy was. So the patient's perception of treatment goal achievement. So this is the standard right now. Of course, this has been published in 2018. So not everybody and not all the studies have done this, but it's a good way if you want to start a study, what you should include. And this is a meta-analysis that has been done a couple of years ago to looking into the outcome of multimodal pain therapy. And the bottom line is the majority had some significant improvement, and I'm showing you here the pain interference. So pain interference is not the intensity, but how much the pain hinders you from doing what you want to do. You can see here that most of them have a direct effect even on pain, but also social functioning is something very important. The authors concluded, and you can see this by the publication date, that the treatment was very heterogenic, depending on modules, content, intensity, length, and also the outcome was very heterogenic. So you have to sort of keep this in mind. But I think that we're on the right track. So I think this is the right treatment for the right patients. Good prognostic factors are, for example, understanding of the biopsychosocial model, normal weight, no severe psychiatric comorbidities, motivation to continue with the treatment, and they also have some boosted treatment. And what I think are the challenges for the future, and that's what we're working on right now, is to implement less cognitive therapeutic elements, because most of our treatment and all the modules that we have, they rely on CBT. So I think more body-orientated therapies or more therapies that grasp the emotional aspects of pain will be needed in the future to also get access to patients that don't benefit from this treatment. We have to look into diversity and minorities, how we can help these patients. Of course, prevention is better than treatment. That's true for almost all the diseases that we know. And we still need to work on the sustainability. So we're exploring digital options or cross-sectional therapy to involve GPs and ambulatory health services to have this a sustainable concept. We are participating in several healthcare studies, and especially the ones that are here in the middle, PAIN 22 and PAIN 2.0, they actually aim at patients at the beginning of the chronifications, and they're quite interesting because patients would just come once a week. So they're sort of low-key programs, and it's easy to implement. You still need some assessment to start with, but you don't have to have like the full program. You can do smaller things and really help patients also a lot to start with. I would like to spend a few minutes on pharmacotherapy and ask a question first. Do antidepressants help against chronic pain? Easy one, yes or no? Okay, so I'm preaching to the converted, I guess. Almost. Yes, they do help, although I was not so sure about it. And there has been, I would just introduce this study, which is the Cochrane database systematic review, which just came out, and it was just good to see. So they include many, many patients, and you have to keep in mind they have chronic pain, but no depression. So it's not just that we're treating the depressed ones. They included only studies with a 10-week duration. Fibromyalgia, neuropathic pain, and musculoskeletal pain was important. The primary outcome was, again, substantial pain relief, pain intensity, mood, and adverse events. And they also looked in other ones. And just so you understand, the next slides is standard dose for duloxetine was 60 milligrams, and for milnacipran was 100 milligrams. And they did a network analysis, and you can already see in terms of the nodes and also how thick the connections are. We have some antidepressants, which are the best ones, and this is actually duloxetine standard dose. Again, substantial pain relief, so minus 50% on the pain scale, and higher doses are not necessarily better. And this is shown a little bit more in this plot, which might be more familiar to me as it was to you as it was for me. And you can see here the highlights. So duloxetine standard, it's this purple one here, and it has a clear benefit. Also, you can use also higher doses, but might not be necessary. Milnacipran is actually quite good, and a drug that I think we don't have it in Germany, so another antidepressant. So this actually was not only pain relief for patients, but also relief for us, because we're using these. And starting from my preparation for this talk, we're not going to use amitriptyline, which used to be our favorite one. We will definitely move over to duloxetine, which is a little bit difficult in Germany because it's off-label. We did ourselves a small study on therapeutic drug management, monitoring in chronic pain therapy. And because we are routinely doing this, especially for duloxetine, you have to be aware that if patients are, for example, smoking, this will definitely lower the levels. And I'm going through this a little bit quicker now. So the bottom line is, I told you before, we used to use a lot of amitriptyline, And what we've shown here, so we analyzed all the patients that had amitriptyline from this retrospective analysis. If we want patients to get better in our therapy, so it's the combination of multimodal pain therapy plus antidepressants. If they have depression, they have to have higher levels, which is what you expect. So whenever you have a patient in multimodal pain therapy with depression, we always go for higher doses, but in the normal patient, we can go for the standard dose. Okay, so the summary of the pharmacotherapy is that duloxetine standard dose is best. Milnacipran standard dose second best and is promising. For all the others, they did not have enough data. I think it has to be individualized, and therapeutic drug management and monitoring is necessary and important. Unfortunately, we don't know much about adverse effects, and in this study, they did not look into the comorbidity of depression and anxiety, and the long-term effects, of course, have not been studied well because this was also only 10 weeks of treatment. So the last few slides, a little bit more about research, and then we come to the Q&A session. So I told you before that we are participating in several healthcare studies to sort of extend what we're doing to other areas. So one is patients at the beginning of the chronification, so the ones that have not been sick for a year or have not been treated with opioids yet. And we have this therapy where the patients just would come just once a week and get a certain program, which is managed by all three disciplines. And also we take care of patients after surgery, and I'm trying to identify the ones that are at risk to develop chronic pain. And we have a transient pain service, which looks at the patient at risk and gives them some special instructions. And also they come after their discharge from the hospital to be seen again and see whether we need some extra treatment. Of course, we're also working on the molecular part. Deep phenotyping and molecularization of pain medicine is my favorite, or what I like to do when I'm not treating, not doing multimodal pain therapy. We're very grateful that we got awarded for this clinical research group by the German Research Foundation, which is actually it's the best funding that you can get, and allows us to work on this and improve pain therapy. And here we are more concentrating on what happens with a group with pain resolution. So what are the factors that make patients better, and how can we predict this? And what are the mechanisms? Can we support them, not only by integrated programs, but also by giving new drugs and certain other drugs. And with this, I would like to come to the end, and I'm asking, what is your take-home message? And then I can tell you what I think is important, and we move to the Q&A session. So what's your take-home message from the talk? Thank you for writing down reduced structural imaging. That's part of my education for the medical students. Body and mind, absolutely. Hope, optimisms, education, medications help. Yeah, absolutely. Pain affects everything. The interdisciplinary treatment, education, the multimodal approach. Thank you very much. And now my take-home message for you is, I think chronic pain therapy is multimodal and interdisciplinary, and this is this combined simultaneous therapy. So the separating body and mind is, I think, not up to date. There are different intensity of programs that can be used. the goal is for the patient to understand that there are also psychological influential factors. Of course, there are biological ones as well. And you can just take home duloxetine in normal doses is best. And I think translational pain research is necessary to understand and subgroup patients better and understand which other drugs that might be beneficial for patients. And with this, I'm thanking my team and thank you for listening. And I'm looking forward to questions and comments and discussion.
Thank you so much, Dr. Rittner. This is Sephora Rosenberg. Yes, thank you. Round of applause. Thank you for a very comprehensive overview, not only of the data, but also some innovative programs and research that you and your team are undertaking. We have many people here in the room and many more on Zoom. So I'm going to do my best to share questions coming from both venues. So I'll give the folks in the room a minute. Oh, Dr. Nichols has a question. I was going to say have a minute to get a question, but here's Dr. Nichols is ready. We have a couple online as well.
Good. Well, hello, Dr. Rittner, and thank you so much. And Dr. Geha as well. This is just really exciting stuff. I'm particularly curious about the expectations that you set out for patients at the beginning of treatment. For example, the expectation of no painlessness. I'm wondering if you've also if there's been any research on the outcomes of patients in multimodal treatments for those who've received such expectations and for those in which they haven't been set out that way, and how much that makes a difference, or if it does.
I think that's a very good question. I think expectation management is something that we have to do even more in the future. We definitely, I mean, it's part of our programs, and I think at least what I understand in Germany, and I guess also in Europe, programs, patients or physicians and everybody who's treating these patients would definitely say so. Of course, patients come with the hope that we will have something special, especially at the university hospital, which nobody had before. And maybe then they will end up not having pain anymore. But if you talk to patients, they would usually understand, or I mean, they know themselves. But dissecting this to separate groups and trying to understand this expectation better is a very good question. And in fact, there is a large clinical research group in Essen by Ulrike Bingel, and she is, well, she works on placebo, but the research group is everything about expectation. And yeah, it's very important on both sides, on expecting something good and expecting something bad, or that nothing happens.
Thank you so much. One question comes in from Zoom. Is addiction, particularly to opioid analgesics, not a contraindication to enrolling in your interprofessional clinic? And if not, can you please speak more to how you work with patients from the standpoint of the interaction between pain and addiction?
Also a good question. In Germany, we have quite strict laws about the prescription of opioids, and we have quite a long tradition for guidelines on opioid use, and of course we have a completely different social system. So when I started with pain therapy, I did see patients that were using excessive doses of opioids, but actually it's declining, and we don't see that many patients that really use like the third level opioids like morphine or hydromorphine is the one that is quite popular in Germany. Oxycodone is not we try not to use it because the addictive potential. If patients are really addicted, then you're absolutely right. We are not the right clinic. But if I think the spectrum between prescription of opioids and full addiction with patients going or doing criminal things to get the drugs, there's like a part in the middle which is a little bit difficult to grasp. Is this because we doctors have been prescribing the drugs and then patients just use more and more? and when does really addiction start? So this is very theoretical. In practice, if patients come with a higher dose, and if they want to get rid of the opioids, we actually do it because we are very familiar with opioids and we know what to expect. And if we think that if they're more than opioid drugs and if there are other psychiatric problems, then we definitely send them to psychiatry. So if it's just opioids and a chronic pain patient, I would be comfortable with that. But if it's more, then this is not the right program.
Thank you so much. Please come and share your secrets with the states about how to avoid an opiate epidemic. I see Dr. Geha has his hand up.
Yes, thank you for the great talk as usual. I just have a quick question. What is the remaining or the use still of diagnostic radiology in this setting? I mean, how much do you use it and how do you avoid it?
Really rarely. If I can give you some examples where we would do this. So if we have a patient and he has never been diagnosed with depression before, and he's diagnosed by us and the psychiatrist with depression, I think this might be the workup for. So we would do an MRI of the head, but for the spine, I really rarely do this unless there is a completely new problem. For example, the patient says, usually I have pain, which is like pressing and it's, I don't know, somewhere lumbar. And then if they start to have a completely new problem, and you know this, then the doctor, they will tell you it's now burning and it's completely a different site and so on. Then I might do this, but I don't know. I'm just trying to think. Maybe it was 1 or 2 during the last 2 months. That's it. I mean, of course, if you have a new patient with back pain and you have treated them and things don't go away, or you have a serious neurological, some neurological clues, you have to do it once, but multiple ones usually don't help, especially if it's the same pain. And patients start to focus on this. They will tell you, well, I have this small prolapse there and this is causing all my problem. And I'm telling them, no, it's the whole thing that's the problem.
Yeah, this is something we also need to do less of here.
Yeah.
Yeah, hi, this is Bob Holloway from Neurology, and I just want to thank you too. It was a great overview and talk. I guess your thoughts on, as we here and elsewhere are developing functional neurological disorder clinics, which are so multidisciplinary. In fact, so much of what you talk about with your pain management approach is kind of how we're trying to envision our FND approach. And and I didn't know if you're overlapping with your methods of CBT and thinking of it more as in some cases like a functional disorder in your approach to treating the pain.
So we have a psychosomatic disease clinic as well. They're smaller and they don't treat the patients with pain. We have different specialities, and I also think that we are moving a little bit towards each other, because I think they used not to have any physiotherapy and no functional training and so on, and now they're doing it because it just helps. I mean, I think I read recently also, same as for depression. If you exercise and you have depression, it just helps. So I think it's the way how we should treat these patients. I was trying to think whether I would say this is a modern way, but it's how we understand diseases nowadays, that it's not just like a certain part of the body that is diseased. There's also like a human being, and treating the whole is better than just focusing on something biological. Does it really answer your question? I wasn't quite sure.
It actually does. It's just the similarities of approaches and the overlaps are increasingly, I think, being recognized. And so the more we collectively think about this, the better, I think.
Yeah, I do think, because the cognitive therapy For some patients, I think that might not be the best start because they might need another approach to understanding the communication between body and mind. Because it really is, it's a lot of cognition and not everybody is the person. I think it's a question of personality and also, of course, also a question of intellectual capabilities. And I do think that we need to find other ways there as well.
Well, thank you very much.
I will, thank you, Dr. Rittner. I will piggyback onto the love of the biopsychosocial approach as your standard of care and ask two questions in one. So I hope that I do it justice. The first is about curiosity about the bidirectional relationship between chronic pain and social isolation and the extent to which you integrate that into treatment. But even more broadly, has there been any exploration of sort of the cost effectiveness of multimodal treatment as it relates to the actual financial impact of the combination of those things, pain, isolation, decrease in function?
Mm-hmm. Yes, I was just thinking we did in fact, we did a small study in Corona about not this multimodal treatment was still running, but we stopped the treatment for elderlies because that was too dangerous. And it was interesting. We looked at the because we always have a questionnaire at the beginning and at the end, and we just compared these different groups. And elderly people did not suffer so much because I'm just saying this now, they are more used to being alone or having remote ideas. That was our interpretation. We were surprised. We thought we would see more. About the cost effectiveness, of course, the therapy is not cheap because it involves a lot of personnel. And personnel is always expensive. But you have to think of the long run. And also you have to think that if patients get surgery or if they get multiple invasive therapy, and if they don't go back to work, this costs more. And we know we have one health insurance in Germany, which is very interested in pain therapy, and they do all these calculations. And I don't know the numbers on top of my head, but they keep telling us that this is cost effective. So, and I think they're health insurance, so they should know.
Well, I was also compelled by a compliment from a health insurance company. So it sounds like you're doing excellent work. Our last question is from Dr. Goldstein. Is training in the use of self-hypnosis for pain modification a component of your program?
It's not, but it's an interesting aspect and also something which would be an option. I know that one of our psychotherapists, she wanted to use hypnosis, sort of also because we have too much, I think we have too much cognitive therapy. And in the beginning, I was not too enthusiastic about it because I don't want this dependency on someone else. Like I don't want patients to be dependent on the physiotherapist. So meaning if they don't go to physiotherapy, they can't survive the next week. They can't go anywhere. And I did not wanted to have this for psychotherapy because the self-efficacy is, or is to be self-confident is important. But self-hypnosis is something different. And in my opinion, it's a little bit close, or it's in the area of muscle relaxation and meditation. And these are actually things that we recommend patients because there's a lot of discussion going on in Germany about digital health, and there are really good apps that you can use. And I keep telling my patients, so there are different options. You can use whatever you want to, but you would need something to, sort of to calm down, focus on yourself. And I think it will work, but we're not specifically using it at the moment.
Well, thank you again, Dr. Rittner, on behalf of the 150 plus attendees from the Department of Psychiatry and the Department of Neurology here. We're very grateful for your time today. And thank you so much to all of you who were in attendance and shared your thoughtful questions.
Yeah, thank you so much for inviting me. Thank you.
Thank you.
Goodbye.